Hello, and welcome to our training video for the Pediatric Delirium and Stem Cell Transplant Study. Over the next 10 minutes, I will provide a brief overview of delirium and describe the proper study methods with a particular focus on best practices for delirium screening. Let us begin by defining delirium. Delirium is global cerebral dysfunction. It is a behavioral syndrome marked by an acute and fluctuating change in awareness and cognition. This occurs as a direct result of an underlying medical problem or as a side effect of treatment. Delirium occurs commonly in seriously ill children, with studies showing a frequency of greater than 25% in the pediatric intensive care unit. There are three major subtypes of delirium. The hyperactive subtype is marked by agitation and restlessness. This subtype of delirium is easy to recognize. However, it represents only the tip of the iceberg. Recent pediatric research has shown that the hyperactive subtype only accounts for 8% of pediatric delirium. The hypoactive and mixed subtypes are far more common. These children often present with apathy and may appear quiet or withdrawn. Studies have shown that without routine screening, this common and severe form of delirium is most often missed by the bedside providers. This is unfortunate, as screening allows for early recognition of delirium when it is most amenable to intervention. Delirium is generally caused by three synergistic processes. The first is the underlying illness that brought the child to the hospital. This is exacerbated by unintended side effects of treatment. And finally, the abnormal hospital environment further increases delirium risk. As an example, we can consider a typical patient we care for in our units. A child with cancer is at risk for delirium due to the underlying oncologic process. He is then exposed to chemotherapeutics, opiates, and sedatives, which are known to increase delirium rates. We then isolate the child in a room for 4 weeks and wake him up multiple times each night for monitoring and procedures. It is no wonder that this child is at risk for developing delirium during the hospitalization. It is vital that we better understand the impact of delirium in our population. In fact, it is a healthcare imperative. Research has demonstrated that more than 50% of adults undergoing hematopoietic stem cell transplantation experience delirium during the peritransplant period. In this population, just like in critically ill children, delirium is an independent predictor of poor outcome. In fact, delirium has been associated with excess mortality, increased length of hospitalization, dramatic increase in medical costs, and even long-term cognitive impairment. So, what do we know about delirium in children after HSCT? Not very much at all. There have been no large-scale studies where children are prospectively screened for delirium during the peritransplant period. We therefore thank you for participating in this important study, which is a necessary first step to better define the burden of delirium in our high-risk children. Now, on to study methods. This study will take place from April 1st through April 10th, 2019. Our goal is to include every patient in the peritransplant period who is present on your service during the 10 study days, regardless of the timing of the transplant. We are interested in children at day -7 and at day +7 and everywhere in between. We will include autologous transplants as well as allogeneic. We will capture children located in the transplant unit and also those children who have been transferred to the PICU. However, we will not include patients who are past their 21st birthday, and we will not include children who have been readmitted to the hospital for post-transplant complications. The most important part of this study is the bedside delirium screening. This is the only aspect of the study that must take place prospectively in real time. The bedside nurse will need to screen the child for delirium each and every shift during the 10-day study period. This will take less than 2 minutes, but it is likely that frequent reminders will be needed to ensure compliance. The bedside nurse will need to complete 3 simple steps near the end of her shift. First, she will need to confirm that the child is arousable to verbal stimulation. The answer to this question should almost always be yes, unless the patient is in a coma. This may apply to a very small percentage of the subjects. For example, those with severe hypoxia who are intubated and very deeply sedated in the PICU. A child in a coma cannot be screened for delirium. However, the vast majority of our patients are not comatose, and most children should go on to be screened for delirium. Step 2 is the delirium screen. We will be using the Cornell Assessment for Pediatric Delirium, or CAPD, a rapid and reliable bedside tool that has been validated for use in children of all ages. It consists of 8 questions that the nurse scores on a Likert type scale, ranging from never to always. It asks about eye contact, purposefulness, awareness of surroundings, and communication of needs and wants. It asks about restlessness, consolability, underactivity, and delayed response to interactions. A score of 9 or higher is consistent with the gold standard diagnosis for delirium. The nurse should score this tool based on her observations of the child over the course of her shift. It is important to remember that this is not a point-in-time screen. Rather, it should reflect an extended period of observation. For most patients, these questions will be easy to answer, but some nurses will feel trepidation about interpreting the items in the youngest patients. Therefore, we will provide you with a developmental anchor points chart that the nurse can use as a point-of-care reference if necessary. These anchor points will orient the nurse as to the behaviors expected of an extremely young child. For example, purposefulness in a 2-month-old is grasping an object. Communication is when the baby cries if she is hungry or uncomfortable. After completion of delirium screening, the final question for the bedside nurse is, were family members present during your shift? After answering this question, the bedside data collection is complete. Remember that bedside data collection should take place twice a day towards the end of each shift. This will allow us to capture a full 24 hours of observation. Also, don't forget to include your patients who have been transferred to the PICU. It will be important not to miss these children, as they are at especially high risk for developing delirium. In addition to the bedside delirium screening, we will be collecting a limited amount of de-identified information for each subject. There is a case report form, which will be completed once on the patient's enrollment. This will provide brief demographic and transplant characteristics. There is also a daily data form that will describe the patient on each study day. This needs to be completed daily, up to 10 times per patient. The research coordinator or PI can extract this data retrospectively from the electronic medical record. We have deliberately limited our data collection so that a full data set should take approximately 10 minutes per subject. Each site will enter their data into the REDCap system, a secure web-based application with validated data entry. We will provide you with a site-specific user ID, login, and password. You will not be entering any identifiable patient information. The study will end in the early morning of April 11th. We will ask you to complete your data entry within 2 weeks with a deadline of April 29th. We then pledge to have all the data cleaned for you and queries resolved by Memorial Day. Remember these keys to successful delirium screening. 1. The CAPD delirium tool is designed to work well even in pre-verbal children. A developmental anchor points chart is available for the nurse to use as a reference if needed. 2. Remind your nurses that this is not a point-in-time screen. Rather, it should reflect the nurse's observations over the course of the entire shift. 3. Reassure your bedside nurses that they should score the individual items exactly as they appear. There is no need to adjust for baseline in children with developmental delay. For example, if a child never makes eye contact, score as never. And finally, there is only a single piece of paper for the nurse to complete each shift, with only 3 quick items that are required at the bedside. We have learned that just-in-time reminders work best. We suggest a walk around the transplant unit to gather forms at the end of the day shift. This will provide an opportunity to remind the nurses to screen for delirium in real time. As for nights, it may be necessary to enlist the charge nurse or fellow on call to help ensure that the nighttime forms are collected before the nurse leaves for the day. Phone calls to check in on the weekend will be much appreciated. This completes the training video for this study. As far as next steps, please complete the brief quiz by clicking on the link in the email you received. It has only 10 quick questions, so completing it now while the information is fresh will be most efficient. We will then send you your login information for the REDCap database, as well as a manual of operations and paper versions of the final data collection forms for your convenience. I am everlastingly grateful for your participation in this study. I will surely keep you apprised of the study results, and I look forward to sharing authorship with you in the future manuscript. Please do not hesitate to reach out with any questions or concerns that arise along the way. Thank you, and have a great day.